Our next presenter is Dr. Emmanuel Yung. He is an assistant clinical professor of physical therapy at Sacred Heart University in Connecticut, and also the faculty at the Mass General Hospital in Boston, and a clinical faculty of the Kaiser Permanente Spine Rehabilitation Fellowship Physical Therapy in Los Angeles. And recently, in September 2023, he received his PhD in ergonomics and biomechanics from New York University, where he was awarded this ERC pilot project grant. So Manny, welcome. It's all yours.
Thank you very much for attending. The title of my talk today will be the association between conditioned pain modulation and the longitudinal response to joint mobilization in adults with chronic neck pain. First, I'd like to thank my PhD committee with deep gratitude for helping me with this study. So neck pain prevalence is about 23% in the general population. Along with low back pain, neck pain costs upwards of $130 billion. It's the fourth leading cause of disability worldwide. Although neck pain can be thought as minimally disabling, less than 22% of neck pain becomes severely disabled at 6 months. And neck pain leads to substantial work absence, presenteeism, and productivity loss. The highest level clinical practice guideline, known as Optima, recommends multimodal physical therapy. Here we'll call it MMPT from here on out. And this consists of exercise, education or advice, and joint mobilization. It is thought that MMPT addresses the multidimensional aspect of chronic pain, which is why it's the most cost-effective of physical therapy treatments. Possible mechanism of MMPT includes motor response from exercise, psychological response from advice or education, and neurophysiologic response for joint mobilization. Here we're going to refer to joint mobilization as JM. And it's the interaction of these three components that seem to address the biopsychosocial aspect of chronic pain. The overall aim of the study is to evaluate the two components, advice and joint mob. We know that advice alone is not helpful. So to evaluate advice and joint mob to limit disability related to mild neck pain called NAD1, consistent with Objective 4 of NORA cross-sector musculoskeletal health research agenda. In that clinical practice guideline, they recommended that for mild and moderate neck pain, exercise needs 9 to 24 physical therapy visits to achieve optimal outcome. For the same optimal outcome, the MMPT only requires 6 visits. And we know that neck pain and low back pain are distinct entities. However, both low back pain and neck pain respond similarly to interventions. And we also know that in the low back pain literature, 1 visit is enough to improve mild low back pain outcome over time. So using that same concept, I use 1 visit of joint mobilization. In this case, it's asterisk with advice as well. 1 visit of joint mobilization to apply them to mild neck pain called NAD1, similar to the mild low back pain literature, and see if the study can achieve the same long-term outcome seen in mild low back pain. This will potentially save a substantial number of visits. We don't really know the neurophysiologic mechanism of joint mob, and that's why it's the focus of the study. One such mechanism would be the conditioned pain modulation, It helps us understand how a person regulates pain in their central nervous system. The CPM can be normal or impaired, and depending on whether it's normal, impaired, or at baseline, it can show how the response to treatment is. Thus, CPM can be a proxy for CNS or central nervous system pain processing. Instead of using fMRI, which is very expensive, this is a very practical, simple tool that can be used in the clinic very easily. So one way to test when someone has normal or impaired CPM is to introduce pressure until it's perceived as pain for both groups, and then apply a noxious stimulus such as cold water, hand immersion for about 2 minutes. In those with normal CPM, they can tolerate a higher amount of pressure before they perceive pain following this cold water immersion. Whereas in those with impaired CPM, they actually tolerate less pressure before they perceive it as pain after the water immersion, suggesting that those with normal CPM can tolerate a higher pain following this noxious stimulus, because this seems to block that perception of pain. Whereas in those with impaired CPM, this noxious stimulus seems to have an additive pain effect from their baseline pain. Therefore, they can only perceive less pressure. They can only tolerate less pressure before they perceive pain. There's 2 studies underpinning and supporting the relationship between CPM and joint mobilization. Courtney et al. Looked at the knee arthritis, Musen et al. Looked at the elbow pain, and was able to show that joint mob normalized impaired CPM and reduced chronic pain. However, this was not done in the spine or neck. So they're able to establish the relationship between CPM and JM. Thus, the specific aim of the study is to determine the impact of 1 JM on CPM and the outcome in chronic mild neck pain called NAD1, and to explore this relationship longitudinally. Here's my conceptual model. My independent variables are baseline CPM and change in CPM following JM. My dependent variables are study variables such as pain, function, and perceived recovery, including the follow-up outcome measures, which are similar. And then the intervention is JM and advice. I have 3 hypotheses, mainly relating CPM with the study variables. So 1, is there a relationship between baseline CPM and baseline study variables of pain, function, and perceived recovery? 2, I want to know if the baseline CPM is associated with the longitudinal outcome of pain, function, and perceived recovery. 3, is the change in CPM after joint mob associated with longitudinal outcome? I have 3 research questions. First, I want to know the baseline CPM in my sample. 2, I want to know the prevalence of impaired CPM at baseline in my sample. And out of those with impaired CPM, 3, I want to know what proportion has normalized CPM following JM. The design is a prospective longitudinal cohort study in 31 participants. The inclusion criteria are 18 to 55, which includes individuals seeking neck pain care, and this is mild neck pain, NAD1, in the chronic stage between 3 months to 5 years. Their pain level should be 3 out of 10 or higher. Neck disability index should be 20% or higher. Exclusion criteria are those individuals who should not be receiving JM, those who cannot tolerate 2 minutes of cold water immersion, those who have received JM and exercise in the past 3 months, those who have moderate or severe psychological risk factors, those who are not working because I'm interested in mild neck pain. In addition to the study variables, we asked the participants not to receive any exercise or JM during the study period of 1 month. The research assistants collected the pain medication use as well as the number of healthcare visits during the study period. This is the protocol. So the research participants responded to a QR code, a flyer, and then they were screened online, and then they came in person and they were screened as well to make sure they're eligible. If they're eligible, the research assistants assess the CPM at baseline. I provided joint MOB to everyone. I'm blinded to all the study variables and outcome measures, and then the research assistants collected and assessed the CPM again after joint MOB. At baseline, the study variables were collected, and then during the follow-up periods, the outcome variables were collected by the research assistants again at 2 days, 2 weeks, and 4 weeks. So this is the descriptive statistics of my cohort. Age is a younger cohort, median at 28. Interquartile range is 26 to 38, which is younger than those typically seeking care for neck pain. The BMI is at the higher range of healthy, and females account for a larger proportion of the participants. None of the participants sought joint MOB or exercise during the study period. 2 individuals have change in their medication, and 3 individuals have reduced their pain medication use. This is the longitudinal trend in pain, function, and perceived recovery. So the pain at 2 days, 2 weeks, and 4 weeks, as well as neck disability index, perceived disability improved significantly, but also clinically. It exceeded the minimally clinically important difference, the MCID, which means that their improvement is clinically meaningful. However, their perceived recovery did not change. This is a baseline for hypothesis 1. I used linear regression, looking at baseline CPM, whether it's associated with the study variables. And it shows that they're not significant, so there's no association between the baseline CPM and the baseline study variables. Hypothesis 2, I use a mixed effect modeling, looking at baseline CPM if it's associated with the longitudinal outcomes. And so the result shows that the baseline CPM is, in fact, significantly associated with pain and function, but not with perceived recovery. The change in CPM following JM, using mixed effect modeling also, to see whether it's associated with the longitudinal trend in outcome, shows that they are not significant. So there's no significant relationship with change in CPM following joint MOB. So the findings, to summarize, the baseline CPM is associated with baseline variables, no. Baseline CPM associated with longitudinal trend in pain and function, yes. And the change in CPM is not associated with the longitudinal outcome. So these are my research question results. CPM at baseline is normal, but it varies between negative to positive. So less than 0 is impaired CPM and normal CPM above 0. Impaired CPM in my cohort, there's 8 of them. Out of the 31, out of the 8, 5 have normalized CPM following joint MOB. And so the discussion is 1 session of JM improved pain and perceived disability up to 4 weeks, consistent with other studies. Other studies have follow-up of 4 days, so my study extended it to 4 weeks. The baseline CPM associated with improved pain and function, it's a novel finding. And third, my CPM change did not associate with the outcomes, conflicts with other studies, and perhaps it's because my cohort did not have a significant change in CPM post-joint MOB. Thank you very much to the ERC pilot project for funding my study.